Next, we'll have Dr. Gorin presenting on PSMA PET.
Just wasted 30 seconds by sitting too far back. Thank you very much for the invitation to speak on this topic, and in particular how it relates to focal therapy and prostate biopsy. For disclosure, and this will come out naturally in the talk, I think is relevant here. I'm a paid consultant for Lantheus Medical Imaging, formerly known as Progenics Pharmaceuticals, and was involved in both the Condor and Osprey trials that led to FDA approval of this agent. So what is PSMA? I guess every talk has to start with this slide. It's a type 2 dimerized transmembrane glycoprotein. Normally, well, not normally, but in other places in the body other than the prostate, in particular in the central nervous system, which is where the molecule was first discovered, it's responsible for the hydrolysis of N-acetyl-aspartyl-glutamate to glutamate and its role of processing neurotransmitters. It turns out that this molecule is overexpressed by prostate cancer epithelial cells. Its role within the prostate is still a bit unclear. However, again, we do know it to be present on the epithelial cells. Now, another interesting factoid about PSMA is that it happens to be overexpressed in the neovasculature of a number of solid malignancies, including renal cell carcinoma, and a considerable portion of my research with PSMA has been for imaging patients with clear cell kidney cancer and defining what subtypes actually don't express it and so forth. And now even Lantheus Medical Imaging is putting forward a clinical trial to demonstrate this, hopefully to update the label for imaging kidney cancer as well. So again, overexpressed by prostate cancer, and its degree of expression only seems to go up, both with increasing grade and stage of the tumor. There is always a lot of discussion about loss of expression of PSMA, or these so-called PSMA negative tumors. I think more discussion of this has been had than is necessarily worth mentioning, especially at this conference, where we're talking about disease that has had no selective pressure by exposure to anti-androgens. Really, treatment-naive prostate cancer, with the exception of, say, the small cell variant or tumors that de novo or neuroendocrine transdifferentiated, should express PSMA and to relatively high degrees. However, with selection with the anti-androgens, though, you will see neuroendocrine dedifferentiation, and we were the first to show that that with that, you start to see synaptophysin and chromogranin go up as you see the androgen receptor go down. So PSMA can be targeted in a number of different ways. What we're talking about today here at this conference is using the small molecule inhibitors of PSMA. There are also the class of antibodies based on the J591 backbone, which was discovered at Sloan Kettering and Cornell, and there are some therapeutic agents that still remain that are built on this antibody backbone. But again, what we're talking about, these small molecule inhibitors. Just for historic context, the 7E11 antibody, which binds to an intracellular epitope. This is Prostate, and this is no longer used because it's quite hard to get an antibody across the cell membrane. So the small molecules that we're talking about that bind to the active site of PSMA, at least the ones that are clinically available for use, are all based on a urea backbone. What they differ in terms of this linkage group here, the radionuclide that's used to allow for detection with PET, and then also the chemistry involved in linking that radionuclide to the molecule. So we have 3 PET radiopharmaceuticals for imaging PSMA available in the United States. Our European colleagues have access to quite a few more. One that you'll see noticeably absent here is PSMA 1007. Rather, what we have available in the US is gallium-68 labeled PSMA 11. My favorite molecule, because it was invented by my mentor at Hopkins, Marty Pomper, DCF-PYL, which also goes by Polarify. And then finally, the new kid on the block, which is Posluma, F18 labeled rhPSMA 7.3. And with these imaging agents, we just are able to have absolute spectacular conspicuity for detecting sites of prostate cancer throughout the body. This is in the phase 2 trial of the Polarify agent that I led at Hopkins, where you could see even even in this patient with a PSA of fairly low number, maybe like 15 or so with high-risk disease undergoing prostatectomy, you could see, sites of disease all over the place, including a supraclavicular or a Burkhouse node. And it's because of, And it's because of all the work that's been put in basically from 2015 to present, where now we have these 3 agents FDA approved. They're part of the guidelines and the NCCN guidelines starting, I think, in around 2022. Why does it keep going forward? Has the statement, because of the increased sensitivity and specificity of PSMA PET for detecting micrometastatic disease compared to conventional imaging modalities, both at initial staging and biochemical recurrence, the panel does not feel that conventional imaging is a necessary prerequisite for PSMA PET, giving all of us the okay to use PSMA PET as our primary imaging modality when we're performing, staging of patients as well as searching for micrometastatic disease, which is pretty similar to the indications that are actually listed on the package inserts from the FDA. I should probably update this slide to also say Posluma as well, because it's the same for all 3 agents. And that is to image patients with suspected metastatic disease who are candidates for initial definitive therapy, as well as for imaging patients with suspected recurrence based on elevated serum PSA level. Notice the label does not talk about using it for performing prostate biopsy, selecting patients for focal therapy, etc. This is really for imaging and staging those patients who have, say, high-risk disease or unfavorable intermediate-risk disease who you worry could have micrometastatic disease. Even though the label doesn't state it, I'm going to show you the results of some clinical trials which are moving us in the direction of probably having an indication like that in the future. So just because I think people like to memorize trial names, I put them all up here. These are the 3 registration trials that led to approval of our 3 agents here in the United States. We had the Osprey trial for Pylarify, PSMA pre-RP, which was done at UCSF and UCLA for the Illuccix kit, which is PSMA 11, and then the Lighthouse trial for Posluma. All of these trials had virtually identical findings, so I'll show you the findings from the trial that I was involved with, which was the Osprey trial for preoperative staging. Basically, patients with high-risk disease underwent PSMA PET imaging and then had a radical prostatectomy of pelvic lymph node dissection. And what we found is that those patients who by conventional imaging were felt to be N0, we had a sensitivity of 40% for detecting lymph node metastases. And if we gated and said that, really only thing larger than 0.5 centimeters was something that we could have realistically detected, our sensitivity goes up to 60%. And with those sensitivities, we had remarkably high specificities approaching 98% in this study. So for suspected recurrence, the 3 trials are the Condor trial for Pylarify, PSMA BCR for Illuccix, and Spotlight for Posluma. These are the results from the Condor trial, where we saw across PSA ranges in patients who have negative conventional imaging but recurrent disease, we're able to find sites of disease both within the true pelvis and elsewhere in the body. Even at very, very low PSA levels down to 0.5, we have a sensitivity of 36% for detecting sites of disease. And this leads to real changes in management. Whether those changes in management matter, I'll get to in a moment, but basically we know that about 65% of patients will have a change in management as a result of their PET-CT, and these could be escalations in therapy or de-escalations in therapy. The question is, does it matter, which always comes up? The answer is with PSMA PET, we don't really know. However, based on the Empire 1 trial, which used fluciclovine, also known as Oxamin, we know it does matter. In this trial, patients were randomized to clinical care-based or standard of care clinical decision-making based salvage radiation therapy versus PET-directed radiation therapy. And you could see that about 32% of patients will have a change in their radiation field based on the results of the Oxamin PET imaging, and that based on the use of PET-CT imaging, patients have a significantly improved freedom from PSA persistence, imaging failure, or initiation of ADT when you make these decisions on the basis of molecular imaging. The trial for PSMA, which is being led by Jeremy Calais at UCLA, is forthcoming. but there's no doubt that with this inferior radiotracer, fluciclovine, we're going to see the same thing with PSMA PET. So how does this all fit into this meeting? Well, there are applications of PET imaging for the focal therapist. We could use it to select candidates for primary focal therapy, and that's in the form of either guiding prostate biopsy or performing initial cancer staging. It could also be used to direct therapy upon biochemical failure following failed primary whole gland treatment. So if a patient's had radiation therapy and you're considering them as a candidate for salvage focal, using PSMA PET as opposed to MRI, which oftentimes we have difficulty being able to delineate lesions because of fiducial markers, treatment effect, and so forth. It has a role in that way. And evaluation in response to treatment following ablative therapy, where we know that MRI offers some of the same challenges as after radiation. So just some of the data. So here's an image of a patient who has clinically localized disease, a negative MRI, but has a lesion on DCF-PYL PET-CT. Really, anyone from across the room could see that there's an area of concern here. This is in stark contrast to sort of doing it with multiparametric MRI. The PIRADS manual is, I believe, 68 pages long. Every year we all sit for an hour or two here with Art and the radiologist, getting a refresher on how to read PIRADS, and year in and year out we forget how to do it. This, anyone could do. We have the ability to do the PSMA PET guided targeted biopsy thanks to our different industry partners. These are images off of the Coella system where I'm demonstrating that you could perform PSMA targeted PET biopsies right out of the box, and I believe all the major manufacturers now offer this. So we have the results from the phase 2 primary trial, which gives us the first look into the potential of using PSMA-targeted PET imaging for guiding prostate biopsy. In this trial, which was led by Lois Emmett in Australia, patients underwent both a multiparametric MRI as well as a PSMA PET-CT. These patients had an elevated PSA level, and so there was a concern for prostate cancer. They then underwent biopsy of any lesions that were identified on either modality. And as we've seen in many trials done before, the sensitivity of MRI was 83%, whereas with the combination, when added with PSMA PET, that sensitivity then goes up to 97%, thus improving the negative predictive value. These results have been recently echoed in the phase 3 PETAL trial, which was recently published in European Urology Oncology, where they found a similar magnitude improvement in the sensitivity when you add PSMA PET to multiparametric MRI. That is about I would say 10 to 15% improvement, and then with that, an improvement in the overall negative predictive value. So, two well-done prospective trials demonstrating these benefits. Really at the heart of this, though, is being able to implement a standardized score so that you know that those bright spots that you're looking at truly are prostate cancer and are worthy of biopsy. We can't forget the fact that the normal prostate tissue does express PSMA, and depending on how you window your images, it's very easy to be convinced that there's uptake in the prostate gland. So those folks who did the primary trial came up with the primary score, which takes into account the location of uptake, whether it's the transition zone or the peripheral zone, the degree of uptake, and then the symmetry of uptake, and arriving at a score similar to PIRADS. And what they essentially showed is that a shift in the area under the curve by about 10% when you implement the primary score relative to PIRADS. There are, future trials underway, which are going to help better define the space. One to take a particular note of is the Primary 2 trial. The Primary 2 trial is for specifically patients with a PIRADS 2 or 3 lesion, and the intention here is to look to see if the addition of PSMA PET could avoid biopsies in patients who have a negative PET scan. So slightly different context than the original Primary 1 trial, and we look forward to that. These are just some protocols from 2 other trials that they published the protocols for, which aim to answer very similar questions like what's the role in active surveillance. I know Tim has a trial like this as well. Further defining the role when patients would say a negative biopsy in the past. And then, every talk here this weekend has also begged the question of what's the role of AI in the future here. And I think, the more complex the imaging modalities, the greater the number of images, probably probably the more ripe it is for incorporation of artificial intelligence. This is actually a really cool paper that appeared in a very obscure journal that I found, where they were looking to see if, based on PET results, based on the match pairing of PET and MRI results, can you take just an MRI image and predict whether or not it would be positive on PSMA PET, thereby allowing you to eliminate the expensive and the expense and extra time needed to get a PSMA PET in the first place. Kind of a cool concept. Doesn't work that well, maybe about sensitivity in the range of 75%, but you could see people are starting to think out of the box about how you could use these imaging modalities in combination and so forth. Like very last slide, then we're done. There's also the question of, can you select candidates for primary focal therapy using PSMA PET, which is kind of similar, but also quite a different question than its role in biopsy. This is a cool paper from Australia, also Lois Emmett's group, where they took patients who met focal therapy criteria, but went on to get radical prostatectomy, and preoperatively were imaged with MRI and PSMA PET, and looked to see how often you could predict occult contralateral disease in those patients. And they found that it added about 5-6% in terms of the overall C-index for predicting the outcome. Sensitivity was a little bit better in the range of about 10% for being able to help select our focal therapy candidates. Retrospective study, all sorts of critiques around it, but it does give us a sense for the potential magnitude that we could see in terms of helping us pick patients for focal therapy. And then finally, evaluating response to treatment. Only a handful of papers on this topic, but basically uniformly show if you ablate something, it should no longer glow, and so therefore there's the potential for it to be helpful in following treatment failures. So conclusion, PSMA imaging has proven to be extremely helpful across a range of clinical contexts, even at very, very low PSA values. It is only FDA approved for staging and for biochemical recurrence. However, you could see that there is a lot of evidence that's emerging and even trials that are still forthcoming, which are aiming to define the role of this imaging modality for performing prostate biopsies, selecting patients for focal therapy, and then assessing response to treatment. And I personally would not be surprised if we see changes to the labeling, or never mind the labeling, if insurers start paying for it for these clinical indications, given the utility demonstrated in these trials. And with that, I'd like to say thank you to the Focal Therapy Society and the meeting organizers for inviting me to talk. Thank you.